Thank you, Savita, for that very, very kind introduction, and perhaps I'm truly humbled, and I'm wondering who this person is. So now for the rest of the story. For those of you who heard my talk this morning, I was asked to talk about the effects of age on the pharmacokinetics and disposition of long-acting drug formulations, since we know that we're going to be seeing a lot more of these formulations being used in our HIV-infected patients, and there are reasons to believe that aspects of aging might affect their pharmacology. My title in the program said intramuscular versus subcutaneous injection. I couldn't for the life of me figure out how I was going to talk about that for 25 minutes. So I'm going to make this a much broader talk. Here are my disclosures. What are the possible effects of aging on long-acting antiretroviral therapy? Well, we heard a lot yesterday about altered body composition and altered physiology with aging. So you could have reduced subcutaneous tissue and altered ratio of fat to muscle. Reduced liver and renal blood flow, probably occurring in other organs as well, for example, muscle and subcutaneous tissue. Reduction in some drug metabolizing enzymes. And finally, effects of polypharmacy and comorbid conditions associated with aging, all of which could in some way impact long-acting formulations. What about body composition? Well, we know that aging can be associated with weight gain, mostly body fat or obesity, or aging can be associated with weight loss, mostly muscle loss, sarcopenia, although as we heard yesterday, sarcopenia in the elderly can include replacement of muscle with fat, so it gets rather complicated if you think fat is an important determinant of pharmacology. So let's address this issue of body composition and pharmacokinetics, particularly obesity or loss of body fat and sarcopenia. Can these two opposite conditions really affect pharmacology? So most lay people who don't know a lot about pharmacology think of the body as being the body. And if you have a big body or a small body and you take the same dose of a drug, the person with the big body is going to have lower concentrations of that drug because they're bigger, and the person with a small body is going to have a higher concentration of that drug because they're smaller. Fortunately for me, the world is a lot more complicated than that. And this is even for me, a simplified diagram of all of the things that can affect the disposition of a drug once it enters the body. From the pharmacologist's perspective, the two most important aspects of drug disposition are these two: volume of distribution. I don't know where we see. Yeah, here we go. Volume of distribution and clearance. It says hepatic clearance here, but renal clearance should be in that bucket as well. Volume of distribution in particular is confusing to the non-pharmacologist because people think of it as being a literal volume, and it's not. What it is it's actually a mathematical term to try to take all of these complicated issues and put them into what I would call black boxes, so we can more rationally understand how to dose a drug in order to achieve desired concentrations. So if you look specifically at the impact of obesity on pharmacology, and I alluded to this earlier, here's a recent meta-analysis published in 2018 on exactly this topic. And here's what it concluded. Volume of distribution is influenced by many factors, and its obesity-related changes are therefore difficult to predict on the basis of drug properties such as lipophilicity alone. Impaired drug penetration in obesity, particularly impaired penetration out of the gut, is important to take into consideration, especially relevant to antibiotics that require adequate tissue concentrations in skin or other tissues. The ultimate influence of obesity on clearance seems to vary depending on multiple drug and patient-related factors, including cytochrome P450 enzymes involved, extraction ratio, which is a mathematical term for how much drug winds up in the so-called effect compartment, changes in liver blood flow and drug transporters, and possibly also duration of obesity. So you take this this doesn't seem to make sense. We tend to think that if your body gets large, your drug concentrations are going to get low, and that doesn't happen. And why is that? Well, it's because, fortunately for us as a species, concentrations of drugs are related more to your ideal body weight than to your actual body weight. Now, how could that possibly be true? Well, it's because concentrations of drug in the plasma or in the blood are related more to liver blood flow and extraction of the drug as it passes through the liver, and those things are not very much affected by obesity. And so the answer to this question of how does total body fat or looking on the flip side, how does sarcopenia affect volume of distribution? The answer is not much. So this is one of the two most important terms in understanding the disposition of a drug. And there's evidence of this with a long-acting formulation. This is looking at the relationship between body mass index and the pharmacokinetics of cabotegravir in the two phase 3 cabotegravir trials, Atlas and Flare. And what you can see is that if you separate people into those with a high body mass in the orange and a lower or normal body mass in the blue, average body mass in the blue, what you can see is that there is indeed an effect of BMI on concentrations of cabotegravir, but only for the first 8 to 12 weeks of administration. And so what happens is that people with higher body mass index do indeed have lower concentrations of cabotegravir initially, but as the drug is continued, their concentrations become indistinguishable from that of people with low body mass. And why is that? Probably it's because people who have high body mass index are having some or much of their cabotegravir depot in body fat rather than in muscle. That doesn't mean that the drug doesn't get absorbed. It means the drug gets absorbed more slowly and released into the whole body. So as you continue the drug over time, although the drug is originally released more slowly, it is released to a complete extent such that at steady state, the concentrations of somebody with a high body mass index and a low body mass index are the same. So let's look at the other important aspect of pharmacology, of pharmacokinetics, that is metabolism and clearance. And we'll look specifically at age-related changes in drug metabolism. I think you all understand age-related changes in renal clearance. But this is interesting. Elderly individuals may have reduced liver blood flow and or reduced phase 1 enzyme capacity. So phase 1 enzymes are the enzymes we know as cytochrome P450s as a consequence of aging and or underlying liver disease. So on average, as you age, there's a 0.5 to 1.5% decrease in hepatic blood flow per year of life, beginning at age 25. So if you're over the age of 25, surprise, surprise, you are already aging. However, and this is also good for our species, the most important drug enzymes are well preserved regardless of age. So your cytochrome P450 3A4 capacity, that's your most important drug metabolizing enzyme, is well preserved with age. And that's a good thing, because were that not true, old people who ate toxic substances would not survive, and our life expectancy would be a lot lower than it currently is. The other important group of drug metabolizing enzymes, the so-called phase 2 enzymes, and that includes enzymes like glucuronidase transferases, or UGTs, are also well preserved. even in patients with end-stage liver disease. And these are the enzymes that are responsible for metabolizing drugs like cabotegravir. So here's one of my favorite studies of drug metabolism in older patients. This is a study that was done by Janice Schwartz at UCSF. She went to a senior assisted living facility in San Francisco. She asked several dozen individuals over the age of 65 if they would be willing to take a single dose of C14 radio-labeled erythromycin and allow Janice to collect their breath to do an erythromycin breath test, which looks at the cleavage of the C14 containing part of erythromycin by cytochrome P450-3A4 that is excreted into through the lungs into your breath. And so you can assess someone's level of CYP3A4 activity with this very specific test. And what she found, this is a large group of men and women. The men are in the boxes and the women are in the circles. What she found was that there was a fair amount of variability in erythromycin breath test results. But overall, on average, this group of individuals aging from 65 to 103 had CYP3A4 activity that was within the expected range for younger adults. So here's clear demonstration of no change in CYP3A4 activity as a function of age alone. In fact, this one woman over here who was 103 had CYP3A4 activity that was right in the middle of the expected range. So let's move from oral drugs and think more specifically about long-acting drugs. So long-acting drugs are generally given parenterally, either subcutaneously, intramuscularly, or intravenously. And as an example, here's an intramuscular drug injection. This would be cabotegravir and rilpivirine, for example. And what you can see is that when you create this intramuscular depot, the drug gets released out of that depot into the systemic circulation. And unlike orally administered drugs, which come in through the gut and the portal circulation, systemic concentrations of drugs for a long-acting drug released from any kind of depot, intramuscular or subcutaneous, are more dependent on release rate from the depot rather than renal or hepatic clearance. And that's because this release rate is so much slower than the ability of the liver and the kidney to get rid of that drug from the body once it's in the systemic circulation. So this is the bottleneck rather than this. So that completely changes how the body handles long-acting formulations. This is called absorption-dependent kinetics, or in some parts of the world, flip-flop kinetics, because rather than clearance being the determinant of drug concentration, it's absorption that's the determinant of drug concentration. I don't actually like that term, flip-flop kinetics, because it makes it sound like clearance happens before absorption, which is not the case. But just keep in mind, this is the hallmark of intramuscular and subcutaneous depots. It's absorption-dependent pharmacokinetics. And the question is, will anything that happens with aging affect that in a predictable way? Okay, another important aspect of these subcutaneous or intramuscular depots is they're complicated. So this is an example of nanocrystals of, for example, a drug like cabotegravir or rilpivirine. Once they're deposited into the tissue, they attract tissue macrophages that try to encapsulate this depot because the body sees this as being foreign. And that encapsulation determines the rate of release of drug. And this is a form of inflammation, if you will. So will that be the same or different in older patients, particularly thinking about it, older patients with HIV? We don't know. I would like to see more data on this, but we don't have a lot of data on this yet. This is an interesting proof of concept here, where they've taken laboratory animals and treated them with a drug called sunitinib, which blocks the particle phagocytosis by macrophages and dramatically alters the concentrations of drug release from this intramuscular depot, in this case with paliperidone palmitate. But paliperidone palmitate is nanocrystals exactly like cabotegravir or rilpivirine, so you would expect the same effect with those drugs as well. I think a more important determinant of variable pharmacokinetics, especially with intramuscular depots, is injection route. And this is a figure from a really informative but small study. This is a study that was published last year in the British Journal of Clinical Pharmacology, looking at the impact of injection route on pharmacokinetics of intramuscular cabotegravir. At least it was intended to be intramuscular. So there were only 8 people who participated in this study. They got their cabotegravir injection with ultrasound guidance. So it doesn't get any better than this, ladies and gentlemen. And despite that, the cabotegravir went everywhere in these 8 individuals. And they know this because they did MRI scans on their gluteus muscles at days 1, 3, and 8. And what they found was that although half the patients had their intramuscular injections remain intramuscularly, several had a combination of intramuscular and subcutaneous deposition of drug. One had completely subcutaneous injection of drug despite intramuscular ultrasound guidance, and one had their entire dose go retroperitoneally. So if this happens with ultrasound guidance in a well-managed research clinic, imagine what's happening in the real world with this drug. The good news, however, is that despite the drug going everywhere, most of these patients maintained concentrations above the target threshold for anti-HIV activity, at least for the first 8 weeks after administration, probably not out to 12 weeks, which was the end of this study. I want to finish by talking about the fact that in the future, I think we're not just going to be seeing subcutaneous and intramuscular drug injection, and this may have an important impact on drug administration in older patients. I think we're going to be seeing transdermal delivery of long-acting drugs. How does that work? This is a cartoon showing how you make a so-called micro-array patch or micro-needle patch. This is, these are, in the corner down here is an electron micrograph of these microneedles, which are formed in this mold system. Basically, you load nanoformulated drug at high concentration into an aqueous gel that's cast into a mold. You add an adhesive border with an occlusive backing. You detach. You can take this whole microarray, slap it on your skin, and detach the base plate. And when you do that, these microneedles, which are consisted in this case of nanocrystals, they deposit underneath the skin into the subdermal tissue and can release drug over an extended period of time, the same as if you had given an intramuscular or subcutaneous injection. What that looks like is this. This is my hand, my watch, same watch, although I took it off. This is a circular microarray patch that was made by a company in Singapore that I put on at they were handing these out at a meeting. I was told this was a placebo patch. I trusted that it was, but I don't actually know. I put this on and wore it for the entire day, and I took it off at the end of the day expecting to see redness or maybe a little bit of bleeding. I saw nothing. These microneedles are like 1,000 mosquito bites with no itch. That's how small they are. And when you apply one of these to your skin, it feels a little bit like putting a piece of sandpaper on your skin. But this is the extraordinary extent to which the science of drug delivery has advanced, and I think is really going to change how we treat our patients going forward in the future. How's this going to affect people who are, in their 90s and have super thin skin? I don't know. I think it's something we need to learn about. But this is the direction we're going in. And these are concentrations of cabotegravir after micropatch application in an animal model. These are rats who were either given traditional intramuscular cabotegravir in the purple or two different microarray patch versions of cabotegravir in the red and the green. And although it's true that the microarray patch concentrations remain above the target for 28 days, so this is a 1-month patch, I need to point out that it's a higher dose to achieve these concentrations, and so I think we still need to learn a lot more if we want a microarray patch to be able to deliver the same dose as an intramuscular dose, but I think we're going to get there. So I'm going to finish with this conclusion. Most body composition and drug clearance changes associated with aging can produce opposing effects on pharmacokinetics. So think about it, for example, your body mass index may reduce the release rate of your cabotegravir and make the initial concentrations lower, but if it's a drug whose metabolism or renal clearance is reduced by aging, then the concentrations would be expected to go up, and those two things might balance themselves out. The bottom line is that for most orally and parenterally administered long-acting drugs, you would expect little predictable pharmacokinetic effects of aging. I think finally it's important to point out that although we certainly have examples of drugs where we change the dose based on the age of the patient, usually pediatric versus adult, and there are examples of drugs, for example, chemotherapy drugs, that are dosed based on weight. There's no example I'm aware of, even though we now have a lot of long-acting injectable drugs out there for various human diseases, there's no example that I'm aware of where a dose or route of administration adjustment is recommended based on age alone. So other fields in the long-acting arena teach us perhaps that this will not be a big issue. I hope that's true, but I do think we need more data. Lots of people to thank, including published and unpublished data from colleagues at Johns Hopkins, Marta Bofito at Chelsea and Westminster, who's my partner in clinical pharmacology crime, as is Katia Marzolini, who's part of our scientific committee, was unable to be here this week. And then a large group at the University of Liverpool. Ryan Donnelly shared with me all of the microarray patch data from Queen's University in Belfast, and I want to recognize my funding sources and also direct you to our long-acting extended release antiretroviral research resource program, LEAP, longactinghiv.org. It is a wealth of more information for those of you who are interested. Thank you.
Yeah.